So this lecture is about the parasites of the central nervous system. Okay, now we go to trematodes. For trematodes, we have two trematodes to discuss, Paragonimus westermanni and Schistosoma japonicum. But I'm just showing you this summary slide wherein Schistosomiasis and Paragonimiasis, which are both endemic here in the Philippines, they're not normally your first suspects for central nervous system disease or central nervous system parasites. We know that Paragonimus is a lung fluke, Schistosoma is a blood fluke, and usually they stay there in the lungs and in the mesenteries or the portal system respectively. But sometimes the adult worms pass through the portal system and the venous system. And through the venous system, they will be able to reach the central nervous system. Also, when they reach the central nervous system, they would lay eggs there for some reason. And both the adults as well as the deposited eggs will be the ones causing your symptoms. Primarily causing a granulomatous reaction. And if you have worms in your brain, we know that the blood supply in the brain, the diameters are very small, they're prone to blockage, which, in this case, a lot of the symptoms are associated with infarctions because of the blockage of the adult worm or the eggs or the granulomatous reaction elicited for the adult worm or the eggs. But I have a few slides here detailing cerebral schistosomiasis. So for cerebral schistosomiasis, we've already had this lecture already. In terms of preference, Schistosoma japonicum tend to reside in the brain if they find their path towards the central nervous system. Schistosoma mansoni and hematobium, they are limited to the spinal cord. And it has something to do with the size and the morphology of the ova of the different species of Schistosoma. So we know that Schistosoma japonicum has smaller ova, and Schistosoma mansoni and hematobium have larger ova, and they actually have spines. If you recall the morphology of Schistosoma mansoni and hematobium ova, they have the spines. And these larger ova and with the spines of mansoni and hematobium, they can't reach the brain, so they just get stuck into the spinal cord. Now, most studies describe cerebral schistosomiasis radiologically. They describe it as multiple enhancing nodules with or without central linear enhancement. Now, the nodules are actually the granulomatous formation, the granulomatous reactions usually associated with the deposited ova, while the central linear enhancement is usually the tract of the adult schistosoma. The most common symptoms of cerebral schistosomiasis, according to Liu et al., a study done in China, this one, Liu et al., study done in China, and Rocha and Giochino, done here in the Philippines, in the Philippine General Hospital, they both conclude that the most common symptoms are actually headaches and seizures. These are the two most common symptoms, followed by focal neurologic symptoms, lumped together, such as hemiplegia, visual or gait signs and symptoms, or disorders. So anything that is associated with a focal neurologic lesion. About 70 to 75 cases for these two studies were actually male. And that is possibly due to, I guess, cultural reasons, wherein males are more at risk. They have more at-risk behavior. And usually the work of males, particularly in the provinces, they work more in the fields, and they are more exposed to schistosoma. Most cases were also diagnosed using COPT, or your circumoval precipitin test, which is a serologic test. I hope you can still remember what that is. And COPT is used because stool exam is only positive on a small number of cases for schistosoma in general. Now, most patients were treated with praziquantel. Some had symptomatic surgical intervention, most likely to treat cerebral edema. But most cases responded well with medical treatment. Now, for the next few slides, I'm showing you some pictures. As you can see here, pictures from Liu et al. You have cerebral edema here. You also have all these hypodense areas here are cerebral edema. These are cerebral edema. Okay. And these dots here, these nodules here, are actually the granulomatous reaction to most probably the schistosoma ova. This one, you have a lot of schistosoma ova. Histologically, you can see the ova. This is the schistosoma ova in the brain. So this is a histopath. So this is the schistosoma ova. And as you can see, or as you can not see, there are no protruding spines. So if you see spines on the ova in the brain histopath, then most probably it's not Schistosoma japonicum. It's another schistosoma species. But in this case, it is Schistosoma japonicum. Now here are several radiographs from the Rocha and Giochino study in PGH. As you can see, it's very similar to Liu et al. Study. You have a lot of hyperdense lesions here. These are the granulomatous reactions. Also have edema here. Some granulomatous reactions. Yes, you have your granulomatous reactions there. You can see here an extensive edema forming where the patient is affected also here. As you can see here, the ventricles are actually dilated. Now let's proceed with nematodes. For the nematode, we have your Angiostrongylus cantonensis. So you also have a formal lecture for this parasite sometime in the near future. But just remember, your Angiostrongylus is your barber-shaped pole parasite. Now, Angiostrongylus has two primary species. You have your Angiostrongylus cantonensis and your Angiostrongylus costarricensis. For our case, for this lecture, we will be talking about the Angiostrongylus cantonensis species. It is the most common cause of eosinophilic meningoencephalitis. Okay, so remember that eosinophilic meningoencephalitis or eosinophilic meningitis. Okay, so what happens there? How do we get eosinophilic meningitis from Angiostrongylus? So usually it's due to the ingestion of the infective third stage larva, usually from snails or the snail parts or where the snails pass through, usually in vegetables, wherein you have the slime of the snails, which can harbor the Angiostrongylus. And these third stage larvae will migrate to the brain and they will die in the brain because Angiostrongylus cannot really live for long inside the human body. But since they are able to reach the brain and they die in the brain, they form granulomatous reactions there. Their dead body forms a granulomatous reaction. And of course, as we know, as we've learned from schistosoma, granulomatous reactions in the brain is not really helpful. So what are the symptoms of eosinophilic meningitis or meningoencephalitis? So the most common symptoms would be headache. The most common symptom is actually headache. But of course, it is a meningitis or a meningoencephalitis. Therefore, you should expect some stiff neck, at least in majority of cases. But not all cases. But if a patient is manifesting with headache, then meningeal signs, stiff neck, and the patient manifested with eosinophilia, then one of your differentials should be Angiostrongylus infection of the brain or your eosinophilic meningoencephalitis. Now, of course, there are other symptoms associated with that, non-specific symptoms. So how do we detect Angiostrongylus? What does it look like? So serology can be used to visualize it. Of course, as I mentioned earlier, a high degree of eosinophilia, peripheral eosinophilia, can give you a clue that you're dealing with Angiostrongylus. CSF examination can also reveal eosinophilia there, elevated pressure, protein, leukocytes. But these are, again, non-specific. The key terms here would be eosinophilia, either in blood or in CSF. So here's a photo, a CT scan image of eosinophilic meningitis. All these hyperdense, small, relatively small hyperdense lesions here, pointed by the arrows. Not the arrows, These are the individual lesions. So you only have, each of them contain one dead Angiostrongylus larva, but it is surrounded by a granulomatous reaction. And that's why it is enhancing. So how do you treat eosinophilic meningitis or eosinophilic meningoencephalitis? Most cases, you don't actually need to treat it. It usually resolves spontaneously in around 4 to 6 weeks. In the rare cases wherein you have steroids, you just do symptomatic treatment. Of course, steroids can be used to minimize the inflammation caused by the dead worms or even the alive worms. And even when they die, they still cause inflammation. Then steroids can be used to minimize those inflammation. Now, anthelmintic drugs, including mebendazole, has been utilized by some studies, by some doctors, to treat eosinophilic meningoencephalitis. But it's a bit controversial because some people argue that killing the parasites aggressively using your mebendazole will actually elicit the release of antigens, and it would increase inflammation. And that's why you give your drug, you have to give your steroid. And according to Tsai et al. In 2001, this particular approach appears to shorten the course of the infection. So from 4 to 6 weeks, usually it only takes about around 1 to 2 weeks, then you'll feel better. The next topic is Toxoplasma gondii or Gondi. So we've already had this lecture, but we will again focus on its central nervous system manifestation. So what happens, just a review, what happens in cerebral toxoplasmosis or in toxoplasmosis in general. So we get toxoplasmosis if we ingest either oocysts or the tissue cysts from infected material. The cysts become tachyzoids. The tachyzoids invade the intestinal mucosa. Then there is widespread dissemination. Primarily, they hitch a ride in the macrophages and they disseminate into the body, including the brain. And when they get into the brain and in some other tissues, they would encyst. They would form cysts, your bradyzoids. Okay, so, what are the symptoms of cerebral toxoplasmosis in an immunocompetent patient? So, in an immunocompetent patient, majority are asymptomatic or even subclinical. So, most people have toxoplasmosis and they don't even know it because their immune system keeps a good check on your cerebral toxoplasma. If ever you are immunocompetent and you develop symptoms, then you have your non-specific neurologic symptoms. And the most common immunocompetent symptom is headache. Cerebral toxoplasmosis in immunocompromised patients is a different matter, as we've learned from the previous lecture in toxoplasma. In immunocompromised patients with cerebral toxoplasmosis develop encephalitis symptoms, which include neurologic deficits, seizures, increased intracranial pressure symptoms, even mass effect symptoms. And this is very, very dangerous. And we know that cerebral toxoplasmosis, it is the most common cerebral mass lesion in HIV/AIDS patients. So if you have a patient who is HIV positive and is actually developing AIDS already, and that patient is manifesting with encephalitis symptoms, particularly your neurologic deficits and seizures, then you have to consider cerebral toxoplasmosis. So how do we detect cerebral toxoplasmosis? So serology is not particularly helpful because most people are actually seropositive, as we mentioned earlier. About 60%, it is estimated that around 60% of the people in the world are infected, but most of them are only asymptomatic or subclinical infections. Now, imaging, especially in immunocompromised individuals, would be very helpful. Okay, either CT scan, it can be also seen in MRI. Of course, contrast would help you detect it more easily and more accurately. And in some cases, ultrasounds can actually be used, particularly for congenital toxoplasmosis. Now, the most common sites of cerebral toxoplasmosis, number one is the basal ganglia. then the thalamus, they're in the same region, and your corticomedullary junction. Okay, so here is an image of your cerebral toxoplasmosis. It's not very obvious here, but this entire thing here is your cerebral toxoplasma. You also have here on this side. That's why you need to have good contrast. I think it's a bit clearer here. This one is your cerebral toxoplasmosis. Oh, and definitely, this is a clearer picture. The entire ring-enhancing lesion here is your cerebral toxoplasmosis. It's also here somewhere in this blurred lesion, but it's covered by a lot of edema. So pathologically, parenchymal toxoplasma lesions have three distinct zones. You have your central avascular zone of coagulative necrosis. So the central zone is your zone of coagulative necrosis. An intermediate vascular zone containing numerous organisms. So inside the central zone does not really have any organisms. But the periphery here contains a lot of organisms there. That's the second layer. And the third layer, the outermost zone, you also have a lot of infections there, a lot of parasites there in the outer zone. Now, here's another photo of your cerebral toxoplasmosis. So this is your lesion. It is ring-enhancing. So it's a ring-enhancing lesion here. And this one, the dark image here, the dark portions, would be your cerebral edema, acting as it's pushing down the brain. The lesion is pushing down the brain and causing cerebral edema. So how do we treat cerebral toxoplasmosis? In most cases, as we mentioned earlier, especially in immunocompetent patients, it's self-limiting. But in immunocompromised patients, you have to treat them immediately. And the drug that you give is pyrimethamine plus sulfadiazine, or sometimes atovaquone. But the key ingredient here is pyrimethamine. And if you followed the news, let's say 5 years back, I think, there's an issue with pyrimethamine, particularly Daraprim. For those subscribed to Netflix, you can watch Dirty Money. So I think the episode there is Dirty Money, Netflix. Okay, next, we have your trypanosomes, particularly Trypanosoma brucei, either brucei rhodesiense or gambiense, or your African sleeping sickness parasites, or human African trypanosomiasis. So we've already had this lecture on this one, but I just wanted to highlight that, of course, human African trypanosomiasis or African sleeping sickness is actually a central nervous system parasitosis. So here's a review, a recap of the life cycle of the Trypanosoma brucei. We'll not discuss that anymore. But the lesion that it causes is acute hemorrhagic leukoencephalopathy. In acute hemorrhagic leukoencephalopathy, there are numerous small confluent foci of hemorrhages. As you can see here in the brainstem, you have a lot of focal hemorrhages there. So basically, your brain, your brainstem bleeds. That's the lesion of African sleeping sickness. So what are again the symptoms of African sleeping sickness? From the previous lecture, the symptoms are, it starts with headaches, paresthesias, mental deterioration, behavioral and sleep pattern changes, but they progress to coma and eventually death. As you can see, African sleeping sickness just starts with a headache and it progresses and progresses and progresses until the patient goes into a coma and eventually dies. So how is it detected? So we've already covered this from the previous lecture. Here is the card agglutination test for trypanosomes used in Africa to diagnose the Gambian form of human African trypanosomiasis. How do we treat African sleeping sickness? So there are specific drugs for African sleeping sickness: pentamidine, melarsoprol, suramine, and eflornithine. Okay, just wanted to highlight again that African sleeping sickness, if you don't detect it early and you are not able to treat it properly, it is almost 100% fatal. And that's why these drugs are very important, especially in endemic countries, especially in Africa. Prognosis of hat, not very good.
In my head like I've seen it, a life worth living is a life